So hi, thank you very much. I feel very honoured that I've been asked to do this webinar. I really appreciate you coming to listen to me, and I'm really hoping that I can share some information with you that you can pretty much go and use tomorrow to improve what you're doing in your practices. So this webinar is Comfortable Dentistry, Talking Techniques and Tips. We'll be doing some techniques and tips, and we'll actually go into some language skill patterns as well that I know that will be beneficial to you. Let's briefly look at agenda. Now we're going to split the webinar into two sections. Historically, you'd do a webinar, it'd be about an hour and 15 minutes. We're trying a new thing here, so we're going to divide this into two. So the first section really is to give you some theory and some information, and then we'll have a little break, grab a cup of tea, and if you wish to then continue, learn a bit more and also gain some CPD, there'll be the second section. So if we look at the agenda for this first half an hour, we're going to look at customer satisfaction. We're going to talk about pain, physiology and psychology. And then we'll also look at some materials and techniques for local anaesthesia. Now the aim of the game for me is to see if I can impart some new information in you so that you can find a way of delivering amazing injections. Or at the very least, understand maybe a little bit more about why your injections are already amazing, because they might already be. My hope is that you're already giving injections where your patients don't even know that they've had an injection. I do that on a daily basis. Even yesterday, a gentleman turned to my nurse and said, "Don't they use injection? Don't they use needles anymore?" And my nurse said, "You've actually already had 4, Mr. Smith." Wasn't Mr. Smith, by the way. So that's what I'm hoping that we'll walk away with today. The second section, after we have a brief interlude, we'll talk a little bit about subconscious influence, and this is something that I've learned over the last 10 years really, and I'll discuss with you the model of communication based on an NLP, neuro-linguistic programming basis. We'll also do some language skills which you can implement straight away, and then what I'd like to do is put it all together. Put together the materials and the techniques that we're using, plus some of the subconscious influence, to demonstrate to you how I give a local anaesthetic, and then I'll show you a video which you can also, if you wish to have that video so you can run through it again, you can send us a text message and we'll send that to you. So grab a piece of paper, please. Grab a piece of paper and a pen, and I'd like you to answer a couple of questions. Just take a couple of minutes. The first question is, when you're about to give a local anaesthetic, how do you verbally set up giving that? What do you say to your patient just before you're about to give them an anaesthetic? You know, how do you set it up? There'll be a phrase that you use more often than not, like, you know, "I'm just about to give you some local anaesthetic," or "make you numb," or whatever. So just make a note of what you do, because we'll come back to this at the end. Second question from me to you is, if you have a nervous patient, what's the one kind of go-to phrase that you use to reassure them? So if you've got somebody that's sat in the chair and they are anxious, what is it you say, or what is it your nurse says to make them feel comfortable and reassure them? And thirdly now, think about the technique that you use for giving local anaesthetic. Just picture in your mind for a minute what it is that you do and run through it and replay it in your mind. And I'm interested to know, do you have a system? Is it already systemized, or do you just kind of get in and get on with it? Are you aware of what you're doing, and do you use a specific technique? And then just put that piece of paper to the side. We'll come back to that at the end of the seminar, end of the webinar. So who am I? Well, hi, I'm Barry Oulton. Thank you very much for having me. I qualified with a BCHD from Leeds in 1993. I started my first practice in 99, so 19 years ago. And I was the first dentist about 20 years ago to attend a sales training course specifically designed for dentists. And I really enjoyed that, and that helped me begin my journey in communication. I completed my DPDS in Bristol in 2001, and I've continued my lifelong learning journey. You know, I've done thousands of hours of postgrad, as I'm sure you guys do as well. I really enjoyed being a VT trainer for 5 years. And then I've managed to complete all of my levels of the Dawson Academy. I was a master level at the Aesthetic Advantage and a senior instructor for them, teaching dentists both here and in the United States how to do smile design. I've then had this practice for 18 years. I had 2 others which I've passed on, and both were successful. And I've been really fortunate in not only the clinical mentors that I've had. I've spent time in people's practices in America, in Istanbul, all over the world. I've been very, very lucky to be coached and mentored by some amazing people. But the same in the business arena, mostly around dental. Outside of dentistry, I've continued educating myself in things like NLP. I'm a master practitioner of neuro-linguistic programming. I'm a master hypnotherapist, clinical hypnotherapist, coach certified and qualified, and I enjoy passing all this information on to people. And the real key change for me was about 2005, when my marriage unfortunately broke down, and I was pretty much at rock bottom, and I did what every sensible person does when they're at rock bottom. They go and walk on hot coals, which I did with a guy called Tony Robbins, and there were some aspects of his course that really gripped me, and I thought I wanted to learn more. And that's where I really started to learn more about NLP, neuro-linguistic programming. Ultimately, it's all culminated in January 2018 of launching The Confident Dentist, and we now provide training to dentists and their teams in sales, communication, in being able to utilize language to encourage and influence people. And I'm enjoying that very, very much. So let's dive in with the first aspect of our agenda, which is customer satisfaction. For me, this is pivotal to my success. Whether you're in a private practice or a mixed practice, customer satisfaction really is the thing that we need to be striving for, because for me as a private practice, if I'm not pleasing people, they're not referring people. And I live in a small town. You know, I've had my patients for 15, 16 years, and they're my greatest source of referrals. So customer satisfaction is where it's at for me. And if you're a mixed practice, a good chunk of your income is going to be based on patients being happy enough to part with their hard-earned money for dentistry that is choice as opposed to need. Stuff like whitening or smile design or orthodontics and things like that. So I'd like to look at 2 aspects of customer satisfaction. Firstly, why patients don't go to the dentist, and secondly, why they do go to the dentist. And studies have been done looking at this. So in 2010, Joe Bulger in Canada looked at the top 10 reasons why patients don't go, why the patients don't come and see you. And these are the top 10 reasons. Have a look at these for me and see what you think. Don't write anything down. I just want you to pick maybe your top 2 or 3 reasons for why you think patients are not coming to see you. And then let's look at these in reverse order. I'll go pretty quickly because as we scroll through, you might be surprised by a couple. So for instance, cost. Cost is a factor, but it is clearly not the factor. It's not the reason people don't come, because it's down there in number 7. And as you scroll up, some of the things you think, really, sounds and smells? Well, actually, yeah, some people don't like that sort of stuff. But the top 2 reasons why patients don't come to you and don't come to me is their perception of the pain and the needle. Now scroll down that top 10, and what you'll see is 7 out of 10 of those are related to pain management. So if we are sensitive to pain management and we become more aware of it, we're going to be nailing 7 of the top reasons why people don't go to you. Also recognise that actually these are all based upon a past experience, not the experience they're having with you today in the chair, but a past experience, or oftentimes not even their own experience. Have you ever had little Johnny who's come in and he's scared, but he's never been to a dentist before? Where's that fear come from? It's certainly not from a past experience because he's not had one. It's obviously come from somebody else's experience, whether that's mum or dad, or a sibling or a friend. Somebody has said something to them that has made them worry and be fearful of coming to the dentist. That's part of the psychological aspect of fear and pain, really. Now let's take a look at why patients do come to you, why they keep coming back. And this was done published in 2004 in America, but by a British woman actually, Jennifer de St. George's. And this was in Dentistry Today. I've actually included number 11 because I think it's super important for me. And that's a well-explained treatment plan. Medico-legally, really important. And actually, with our treatment coordination in my practice, this made a huge difference. is being able to sit calmly out of the surgical environment, explaining options and giving financial choices. Huge, huge benefit. So as we go back again in reverse order, scrolling back through the reasons why patients do come to see you, what you'll see is that they value the relationship. They value a thorough examination, a dentist that listens and doesn't treat them as stupid when they ask a daft question, or their perception of a daft question. They like being looked after by the staff. You know, they're calm, they're professional, they're caring. And again, the top two. The top two reasons why patients keep coming back to see you or keep coming back to see me is the dentist doesn't hurt. You know, he or she was fantastic. There was no discomfort. And the number one reason was a comfortable injection. My dentist, I didn't feel a thing when they gave me an injection. And I want to encourage you to start to look at where you sit in terms of that. Because if you look at these two main areas of why patients do come and don't come, the needle is the top reason why people do and don't come, and the pain is number two. So where do you sit in terms of customer satisfaction? Do you ask your patients, do you say to them, how was that injection, or how was that treatment? And when you ask, do you listen to the answer? And do you look at how you might be able to make it better? Because I found that in our practice, enveloping great technique with great materials and some careful language and the way that we handle our patients has made a huge difference in our recommendations, in our patient satisfaction surveys, and ultimately in the bottom line and the profits. So I'd encourage you to ask, develop a system that you're happy with, ask, get feedback. You want 10 out of 10 every time you're giving a local anaesthetic. So let's look a little bit at pain, the physiology of pain. Now I need to give a disclaimor. All of the brilliant illustrations in this webinar have been drawn by my friend Andrew Mason, outstanding guy up in Dundee, and he's painstakingly drawn all of these images, and he's very kindly allowed me to use them, so my gratitude goes out to him. Pain, defined by the International Association for the Study of Pain, is it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Let's divide that up. Yes, it's unpleasant, but the interesting thing to me is where it's sensory and emotional, actual or potential. So we know that sensory is the stimulus, okay? I stab myself with a drawing pin, there's a sensory to that, but then there's an emotional attachment as well. And they, in 1979, when they came up with this definition, they recognised that there was an emotional aspect to pain. What they didn't realise is actual or potential is not what I now take it for. Actual potential is, for me, whether there is actual or potential, whether or not there's a stimulus or not. So, for example, an actual stab in the finger, generally speaking, that's going to produce a sensory or an emotional response. But what we know from studies and neuroscience is that just the potential of stabbing myself or being stabbed in the finger can produce that sensory and emotional. People can feel pain without the stimulus. People can have a psychological reaction to pain without a stimulus, and we know that. And interestingly, the IASP accepted that definition of their own definition. They accepted that version in 2010. So we know it's unpleasant, we know it's sensory, but a couple of definitions. Nociception is the activation of the neural pathways by the stimulus that either damages or threatens to damage the tissue. The noxious stimulus is the potentially damaging stimulus, like the pin in the finger. And the nociceptive stimulus is the thing that activates the nociceptive pathways, okay? Now, what is the pain experience, and what can it depend upon? Well, firstly, the pain experience of any patient is different for each and every patient. It can depend on the strength of the stimulus or the degree of tissue damage. A huge contributing factor is the emotional state. So I already thanked Andrew Mason for his wonderful diagrams. And this is actually Andrew Mason himself. This is his hip. Andrew was cycling to play in a concert, and he fell off his bike. And unbeknownst to him, because he was so focused on getting to the concert, he didn't realise that he'd quite seriously damaged and fractured his hip. He got back on his bike and continued to cycle for a further 5 miles. The only thing that stopped him is his chain fell off his bike, and as he got off his bike to fix his chain, because his focus of attention and his emotional state changed, it was only then, after 5 miles, that he started to feel the incredible searing pain from this fractured hip. So emotional state is hugely important. We've seen footballers who have been playing football for 30 minutes with a broken leg or a broken foot and not realised it, because their focus of attention was on playing the game or winning the game, and it's only after the game that they realise that they've done some serious damage to themselves. Another factor is past experience of pain, and we know this from scores of studies, is if somebody has experienced pain, let's say dental pain, they've never come to see you for treatment, but they're incredibly fearful because they experienced a pain in the past. They're already on edge, worried about that because of a past experience, even though it doesn't relate to you. And then there are other factors that can affect the pain experience. The first definition of pain came from Descartes, who was a French philosopher. And he basically said this, that fast-moving particles of fire passing along the nerve filament until they reach the brain, and that's pain. And it's very oversimplified, although that is a very, very tiny brain. Because he kind of simplified it that there was just one kind of tube running from the peripheral stimulus up to the brain centre where we felt pain. And what we know is that it's much more complicated than that, because there's at least 3 nerve fibres involved with 2 synapses. And those synapses are one in the brain stem and one in the thalamus, and that will determine then ultimately what gets up into the cerebral cortex. And actually those stimuli can be affected at both of these centres, both these synaptic areas. So let's look for a second at the nerve fibres that are actually contained within the nerves themselves. If we look at this, there are 4 main classifications of nerves. And what you'll see is some are really skinny without any jackets on. And then some are quite fat and they've got big woolly coats on. And they're myelinated and unmyelinated. And what we know is that the big thick nerves that are myelinated and insulated transmit their impulses super fast as a plane. And the skinny little ones without any jackets on transmit their impulses really slowly. C and A delta fibres transmit pain. They're the nociceptors. And then A beta and A alpha, well, they're the ones that transmit mechanoreception, and they're muscle fibres as well. And they're the ones that are super fast. And what we know is, as this stimulus comes in, they're drawing pins down on the bottom. As the stimulus comes in, it runs through the nociceptors up to the brainstem where it has its first synapse. It then runs into the thalamus where it has its second synapse. And what we know is that at these 2 centres, this is where the perception or the signal can be either dialed up or dialed down, but it can be altered, it can be influenced. And this is where our current theory of pain comes from. Now, it's quite old. It's older than me. It's 1965. Malzek and Wall, and this is the gate control theory. And they were trying to explain how pain signals can be modulated. And in essence, what they said is, when you have a noxious stimulus on the periphery, this drawing pin on the outside, that pain signal travels through A delta and C fibres, the nociceptors, up to the point at which there has a synapse with a second order neuron. And it's at this point here that the signal can get through or be blocked. And the signal can be blocked by another impulse that may be perhaps travelling faster. So, for example, this is where, when little Johnny falls over and bangs his knee, we go up and rub little Johnny's knee. And we're stimulating the mechanoreceptors. And those mechanoreceptors, if you remember to the picture, they travel like a racing car or even an airplane. They travel through to this first synapse and they get through the gate, closing the gate to the noxious stimuli coming from the A delta and C fibres. So in essence, if we stimulate the area with a faster impulse, it gets through, closes the gate to pain, and we don't perceive pain. And we do this inherently. This is within our subconscious. We automatically will rub an area when it's sore. So we kind of know this. Now, there's been equipment that's been brought out to help us as dentists give injections by utilising the gate theory. This is an example. This is called Vibrajet. Theoretically, it's a good idea. It vibrates on the shank of the needle. The problem is that it's quite heavy, and actually patients reported that it was uncomfortable. But theoretically, not a bad idea. The other thing that can alter the perception of pain is what we call top-down modification. It comes from a higher centre. This is kind of like Andrew falling off his bike. but his focus of attention is getting to the concert. So he doesn't think about pain, it doesn't get there, because he's just thinking about getting on with the job and getting where he needs to get to. But this is also where we're influenced by our memories, by our past experience, by language, by things that we are exposed to outside of us that can influence our own perception of whether pain is there or not. So let's look a little bit about psychology. Again, multiple studies tell us that we know physical stimulus can prompt certain feelings and responses, but also so can psychological stimulus. They ran a study. They took a group of young computer gamers and they got them really fully engaged with this brilliant game. And whilst they did that, they used functional MRI scans to monitor their brains and the activity in their brain. And at a certain point in the game, they unfairly excluded them and cut them off and monitored the cerebral cortex. The areas that were stimulated by this unfair act were the same areas that were stimulated when these guys were stabbed with a pin. So what they discovered in this sort of research was that actually psychological pain can be actually the same as a physical pain. It can affect the individual in the same way. And multiple studies have backed this up. You look at emotions affecting pain and different factors within our own patients. And you look at dental pain psychology, and we know that actually younger, more educated patients report higher levels of pain, and those with previous experiences report higher levels of pain. So there's a big psychological aspect to it. And it was Milgram that said that one of the most ironic things is the very procedure that allows patients to be treated virtually pain-free is the one that they fear the most. So if I can encourage you and we can collectively become amazing at giving completely comfortable injections, we're using amazing equipment and amazing local anaesthetics that mean that then the treatment we're providing is completely comfortable. We can begin to shift the perception of dentistry and pain. You know, you ask patients and they automatically assume dentistry hurts. Well, no, it doesn't. Not if you're doing things in the way that ensures that it's completely comfortable and you use the right language and the right equipment. It can be completely comfortable from start to finish. And that has a big impact. That's what it's a treat for me in my practice. And I'm going to hopefully encourage you guys to look a little more into how your injections are so good or how they can be even better than they are. So what affects pain perception? Well, the context. You know, where you are and when the pain comes. If you're in a boxing match and you get hit, you're going to expect to get some pain. You know, if you're sat at home and you get hit, you don't expect to get some pain. So context, you know, has an effect. Attentional distraction. I utilise distraction all the time when I'm particularly treating kids. I'll distract them, or a nervous adult. I'll ask them to wiggle their big toes. Can you wiggle your toes without wiggling your little toes? So I've invoked the gate theory. So that gate theory, I'll stimulate by rubbing the gum or gently wiggling the lip. And as I've used topical anaesthetic, I've wiggled my cotton bud, I'm about to engage the needle, I'll ask the patient, can you wiggle your big toes without wiggling your little toes? I shift their thought process down to their feet. I've distracted them. I go in the needle. I drip feed the local and they don't feel a thing. So attention, if they're thinking about it, they're waiting for it. If you distract them in some way, it works an absolute treat. So anxiety, fear, loss of control. We have conversations saying everything's going to be comfortable and you're in control. If it's anything other than comfortable, please just lift your hand up and I'm going to stop and make sure that we look after you. And we start that conversation prior to giving our local. That's my setup for local. I don't actually talk about the local. I talk about the patient and making sure that they're going to be comfortable. Their memory can affect pain perception. They might have learned pain from somebody else. They're either their own experience or somebody else's. But also expectation, because if they expect it, they're going to feel it. So this is where, if I've got somebody with an expectation, I'm going to distract them. And beliefs. Beliefs are huge. Dentists hurt. Really? This dentist doesn't. And this is all centered around top-down modification. And actually, all of this can be affected by our communication. So let's take a look at the materials and techniques. I want to look at the basic technique of giving a local anaesthetic. We're going to look through topical, our needle choice, the system that we're using, anaesthetics techniques, and bevel, really important when we're giving a local anaesthetic. So topical anaesthetics, surprisingly, only 40% of patients on average benefit from this. I would wholeheartedly encourage you to use a topical anaesthetic, even for the top-down modification, even if it's a placebo effect. We know that it's not. We know we don't get deep anaesthesia, but we certainly get surface anaesthesia. But actually what we get is we get this caring attitude towards the patient. So I use topical anaesthetic on everybody, and I'm very mindful of telling the patient that I'm using this bubblegum gel, or I'm using this topical gel that I'm rubbing in that will numb the gum so that everything is comfortable. So I'd encourage you to use a really good topical anaesthetic like either of these two. The next thing we're going to use is a great needle. Now, obviously, all I use is the Septodont products. They're super sharp and they're beautifully made. You've got to be very careful if you're just buying own brand stuff, because some of them are not manufactured in the same way. And those needles at the top that you can see, they're going to cause discomfort and damage. And so please make sure that you're really choosing the best needle that you can. Nowadays, for safety of yourselves and your staff, you really should only be using Ultra Safety Plus. These are non-resheathable. They've got a safety system. Different sort of handles, whether they're disposable, autoclavable, or stainless steel, they do the same job. For me personally, I use the middle ones. They're autoclavable. And I'm using Ultra Safety Plus, which means that we've, in the last, the last 15 years, we've not had a needle stick. And this is completely against what you should be doing. This was actually a photograph sent in to the MD of Septodont from a dentist complaining that the needle had come through the side when he resheathed it. So the bottom line is, don't resheath it. Just use the Ultra Safety Plus. It clicks off and then no one's going to get hurt. Local anaesthetics. So my local anaesthetic of choice for the last 10 years has been Articaine. Articaine is different from all other local anaesthetics because it has a thiophene ring and it's much more lipid soluble. And the benefits of being lipid soluble means that actually it penetrates the bone way better. But as you can see from the slide, typically, historically, LAs are divided into esters and amides, and the most used one are those bottom four: lidocaine, prilocaine, mepivocaine, and articaine. I'm a big fan of using articaine myself as a buccal infiltration instead of a regional block. Personally, I don't really do IDBs anymore. I do perhaps maybe 2 a month, and the only reason I will do a regional block is when I'm treating at least 3+ teeth, maybe 4 teeth in a quadrant, and rather than giving multiple buccal infiltrations, I'll give a block. That being said, it's few and far between. It's much easier for me to be giving a buccal infiltration. In actual fact, I'll give a buccal and I'll give a lingual, and I'll show you the study that explains that very shortly. But I'm using articaine in almost every single injection I give. Personally, just for habit, if I'm giving an ID block, I'm using Cytonest. There's no contraindication to using articaine. You know, there's a gazillion studies. When we were at uni, we were told not to give an ID block with articaine. It's not true. There's no study that's demonstrated that it shouldn't be used. In actual fact, all of the studies have said that the articaine by infiltration was as good as an inferior alveolar block using lidocaine. So in my map of the world, I'd much rather do the picture on the left than the picture on the right. And we know that articaine, having that thiophene ring, if you look at the kind of way that lidocaine seeps into the bone, we know that actually articaine gets further. So with articaine, if you give a buccal infiltration on the upper, it's going to reach the palatal root because it manages to penetrate the bone better. I also get, personally, my personal experience is that I get a faster onset of anaesthesia with articaine. And I find that my patients are just completely comfortable. In the lower arch, I'm using infiltration. On a premolar, I'm just doing a buccal infiltration, particularly around the mental foramen. And actually, with a molar, oftentimes, depending on the procedure that I'm giving, I'll give a buccal and a lingual. And if you look at this next slide, actually, this demonstrates a study that was done by Meekin and Ledvinka, and they took a mil of lidocaine and gave it purely buccally for the lower incisors, and they had a 50% success rate of anaesthesia. They gave the same to a different group lingually, and again it was 50%. They divided that 1 mil into 2 halves, and they gave half a mil at the front and half a mil at the back. They got a 93% success. So what we know is that the way that local anaesthesia penetrates the bone, you're actually better off giving a lingual injection as well as a buccal infiltration. If I go back a slide, if you do that with articaine, you're getting better penetration of the bone anyway. So my technique in the mandible, if I'm doing 1 or 2 teeth anywhere in the arch, I'm going to be giving articaine buccally and lingually, and I have, again, something like 93% success rate, there or thereabouts. Rarely do I need to do an interligamental, or I'll go through the papillae to go through the crestal bone. But articaine for me is the go-to anaesthesia. Again, this study demonstrated that actually it's as good as. So why would you bother doing anything else? Why would you bother yourself doing an IDB when a buccal infiltration is as good as and is easier? It's just a simple thing to do. So let's talk a little bit about the bevel. Bevel direction is really important. This is classically what we think we need to do with it, and it is when you go into the bone, is you want the angle of the bevel being parallel to the surface of the bone. Why? Because if you look at the picture on the right, you don't want to be bashing the tip of the needle into the bone, because A, you're directing the local anaesthesia away. I don't think that's a big problem, but what I do see as a big problem is this. If you can imagine giving an ID block, and you go and touch bone with the tip of that needle, and that second or third picture occurs to that needle, you're completely unaware, and then you withdraw, and just imagine that one of the important nerves is touched by that. This is where you're going to cause damage. This is not a local anaesthesia problem. This is the problem if you've bashed the needle into the bone. You've got much less chance of bending that needle if you've got your bevel direction correct. So how do you know if you've got your bevel direction correct? Well, if you look at your needles, if you don't already know this, what you're really looking at is that black mark there on the hub of the needle. That black mark coincides with the bevel on your needle. And we utilise this every single day, because if I'm going to be giving an upper infiltration, my nurse will pass me that with the black mark facing upwards, because I want that bevel of my needle to be against the tissue, and I'll show you why. This is typically how we would, previous to understanding the bevel direction, this is typically how we would have given an injection. We'd have used topical anaesthetic, obviously. Now we know that if we're lucky, anaesthesia from a topical for around about a minute is going to give us maybe half a mil depth of anaesthetised surface tissue. You approach from a perpendicular direction and you begin to insert the needle. Now right now we're in that area of anaesthetised tissue. There's zero discomfort. Even with your loops on, it's quite hard to tell that you're at that level, but let's just assume we can. Once you penetrate through that level, this is where the patient starts to feel discomfort. It begins to be painful. You progress the needle further, you progress it further, the patient starts complaining of pain, so what do? You start to inject your local anaesthetic. Well, look at that bevel of that needle. It's encased with tissue, but it's not fully impregnated. So have you ever seen this? Have you ever seen your local anaesthetic kind of wash over the mucosa? Well, yeah, you have, haven't you? Because I've turned around to patients and go, oh, terribly sorry, it doesn't taste very nice. Well, this is where you don't get the very good taste. You haven't penetrated the tissue far enough. So what do? You go in further, right? And the pain increases. You've got an unhappy patient, you're then injecting that local anaesthetic, and all in all, that's an uncomfortable injection. So this is our technique. Back to the topical anaesthetic. It's given us about half a mil of anaesthesia to the mucosal surface. I know where my black mark is. My black mark indicates my bevel. I'm heading towards the tissue. I've got the tissue deflected so that then I'm engaging the bevel parallel to the surface tissue, and we start to engage in. Now at this level, we're still in that anaesthetised anaesthetised section. Patient doesn't feel a thing. I'm also gently vibrating or rubbing. I'm distracting, so I'm invoking the gate theory. So I'm distracting with touch. I'm distracting, asking them to wiggle their toes. I'm going in at such a very minute level, and I drip, drip, drip very, very gently. 4, 5 drops, that's all I'm going to do. And at that point then, that anaesthetic is beginning to anaesthetise the surrounding tissue. You can then begin to penetrate more. My preference actually is I'll take the needle out and I'll let that work its magic, because after that's anaesthetised, maybe 30 seconds, I can then go in a perpendicular direction or more parallel, and my patient's completely comfortable, as you'll see later on. So we penetrate through, we follow the line of the injection. You inject that local anaesthesia really, really slowly. Now, really slowly. That's like a mil a minute. Get a needle with some local, and do me a favour and drip and time a mil a minute. You'll be so surprised at how slowly that is. But I want you to picture a really lovely piece of fillet steak, right? And you get a hose pipe. You turn the hose pipe on, and it's just dripping water. It's just a very slow drip. And you drip the water onto that fillet steak. There's no damage, there's no issue, it just makes it wet. Connect that same hose pipe up to a high pressured hose, and because it's pushing it through such a small tight bore, the pressure increases, and you can actually cut through a steak with a high pressure hose. It's the same volume of liquid, it's just because it's high pressured it can cut through. Now imagine that is your injection technique. Imagine that you go in and you want to get this done and dusted as quickly as possible for your patient. You've got all the best intentions. You squeeze really hard to whack in a mil, and what you're doing is you're actually power hosing through that tissue. You're causing damage and discomfort and possibly inflammation and possibly discomfort for the next few days. Be super, super slow. Take your time and drip, 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 and your patient won't be aware of it. So with that in mind, let's take a break. We're going to have a break for about 5 minutes. Grab a cup of tea, and if you wish to come back, and we'll do some NLP and we'll do some language skills, and I'll share some more information with you. You'll be able to then gain some CPD. So please take a break, and I'll see you in about 5 minutes. Thanks a lot. Welcome back. Part 1 was really about the theory, a bit about pain, physiology, psychology. The materials that I would encourage you to use in terms of good quality needles and good quality local anaesthetics, and a bit about the technique. And also then about the use of the bevel position and how we can introduce the needle without the patient being aware. This part 2 is about subconscious influence. I'm going to talk about the NLP model of communication. I'm then going to talk to you a little bit about language skills, how we can use specific language and avoid certain language in order to positively influence our patients. But you can use this outside of the practice and with your family and team members and friends as well. And then we're going to bring it all together with a video on how I give a local anaesthetic. This is a new patient, second visit, in for her first filling with me. And then I'll also show you that video again annotated so you can understand the individual steps so we can culminate it all together. I'm going to cover a bit about subconscious influence. Now, I learned NLP about 8 years ago. Fundamentally, it's shifted everything. It's affected my personal life, but also my professional life. And actually how I look after myself as well. So let's talk a bit about the NLP communication model. Stuff happens, events, a bit like this webinar, whether you're sat at home or in your office. You are being hit by a bombardment of information through your senses. And that amount of data that's hitting you is considered to be around about 12 million bits of information per second, postulated by a guy called Mihai Csikszentmihalyi in a book called Flow. And we're visual, auditory, kinesthetic, olfactory and gustatory, our 5 senses, so it all comes at us, okay? The thing is that we can only cope with 134 bits of information per second consciously. Some psychologists talk about the fact that some patients have sensory overload, so they're aware of much more of the sensory information coming into them than you or I are, and that's why they're mad. So in order to reduce that 12 million down to 134 bits per second, we go through a number of filter systems. The first thing we do is we delete things. For instance, if I ask you, are you aware of the chair on your bottom? Well, you are now, right? Because whilst I was saying it to you, you weren't aware, and then I've encouraged you to become aware of it. Are you aware of the sounds around you? If you think for it, have a little listen. What can you hear? Can you hear something buzzing? Can you hear the computer? Children in the background or something on the street? You're not aware of that until I ask you to become aware of it or something changes. We can only hold on to 134 bits per second and in chunks, 7 plus or minus 2 chunks. So when I throw you a new piece of information to think about, or a chunk, you effectively drop another piece of information. So think about the foot or the sock on your right foot, or the shirt on your back, or now be aware of the furniture in the room. We delete stuff, and that's how we filter it down. The next thing we do is we distort things, so we can change information based on our past experiences or based on our perceptions of what's going on. So, for instance, if you've ever heard a noise in the night in your house and you go, somebody's in the house, and then you find out that actually it was the cat, or it was the central heating moving, or something creaking, that's distorting. The next thing we do is generalise. We kind of lug things together. So take a look around in your office or your home or wherever you are. Have a look at furniture, different types of furniture, tables, chairs, beds, cabinetry, shelves, all the different things that actually you start going, oh, actually there's a lot of different stuff, but we generalise it as stuff. So that's what we do. We condense the information so that we can handle it, right? But that means that your 134 bits per second is different from mine. And that's why police reports from 30 different eyewitnesses are all different, because they hold on to different bits of information. Once all of that comes into us, it then goes through our own unique filter system. And our own unique filter system is things like time and location, the mood that we're in. Our meta programs, they're things like they're our personality preferences. Our language, the language that can change it, our own memories, our own previous decisions, beliefs and values, and actually things like identity. Identity is huge. Let me give an example of time and location. So I phone you up 3 o'clock in the morning. I ring you and it wakes you up, so you don't answer it. I ring you again, you don't answer it. I ring you a third time and I go, hey friend, can I borrow £1? And you go, what the really? 3 o'clock in the morning? Really? Let's say I phone you at 3 o'clock in the afternoon and I go, hey friend, can I borrow £1? Your likely response is, yeah, sure. Are you alright? Barry, you need £1? Same messenger, same words, same tonality, same information. The only thing that was different was the time and the location. And it had a completely different meaning to you. Now that meaning is what we call the internal representation. It's what we form to represent our interpretation of all that information that's coming towards us. That is either a picture, a sound, a movie, or our own internal self-talk, our little conversations that we have with ourselves. That internal representation has an effect on our mood, our state of mind, our emotional state. And actually, our emotional state, conversely, can affect our internal representation. So if you've ever been in a good mood, it will affect how you represent things in your head, as opposed to if you're in a bit of a bad mood, you'll change that. You'll have a more dismal look at the way things are. Or have you ever misread somebody when they've said something to you and they go, no, I didn't mean that. And you kind of go, oh, I was in a bit of a bad mood. You just assumed that what they were saying was negative, when in actual fact, they might have been being positive. That's the sort of effect I'm talking about. And that's the sort of thing that can happen to our patients when they come to us. Past memories, past experiences can change their internal representation of what's happening, or their representation of what's going to happen. So that can be affected by our body posture, our physiology, particularly our breathing. Our breathing position and rate can drastically change how we're feeling. That can affect our internal representation, and actually the whole thing filters every second. It's interrelating. Those things collectively will affect our behaviour, and it's our behaviours that ultimately result in our results. So as a NLP practitioner helping my clients or my patients, I'm able to help my patients get better results by changing their behaviours, by influencing either their internal representation of what's happening, their emotional state, or their physiology. And I can change one of those and it can change everything. So I can get them to jump up and down, change their breathing, and they just feel better. Have you ever felt really rubbish? And then maybe you've done some exercise or gone to the gym, and within a heartbeat you feel completely different. That's the sort of thing. You're changing everything that's going on by changing your physiology. It has a knock-on effect. So this is important about how we can interact with one another, with our patients, with our loved ones. If we understand this, we can help people change their representations of what's going on. And in essence, our mind is made up of our conscious mind and our subconscious mind. And based on Mihai Csikszentmihalyi, our conscious mind is just a tiny percentage, less than 0.06% of our mind, whereas our subconscious mind is way bigger. It's like 99.994%. At this point, I would love to show you a video. It's about a 7-minute video. At the end of the webinar, I really would like you to click on a YouTube link. You're allowed to go and watch it. Because of copyright, I'm not allowed to play it, but it is a video of a fantastic demonstration of subconscious influence, of seeing how, whilst we're only consciously aware of that small 134 bits per second, our unconscious mind, that 99.994% of our mind, is actually taking everything in. And this video will demonstrate that to you. It is been recorded for entertainment purposes, but for educational purposes, it's fantastic. It's Darren Brown, and he is utilising this knowledge and understanding to influence some marketing advertising people. So I'll give you the link at the end. Please go and watch it. The beginning is that. So, is what we say important? Well, for me, it's probably way more important than we even realise. And I'd like you to watch a second video. Now, I'm going to describe this video to you. Darren is in a medical university, and he's got 4 medical students, and he says he's going to do something and an experiment with them. One of them chooses to leave. And using hypnotic language, using just the power of language and influence, he's able to give all 3 of the remaining students the sense that they have a toothache. And then he's able to influence and hypnotise this younger gentleman into sticking a needle through the back of his hand. And the guy sticks a needle through the back of his hand, doesn't feel a thing. I'll give you the link at the end. It's well worth watching. What this demonstrates is that simply by the power of language and influence, we can change somebody's perception of pain. Now, I'm not advocating that we stop using local anaesthetics. I'm not saying that you should learn how to do hypnotherapy. I'm a qualified hypnotherapist. I don't use that purely in my practice. Another final video from the BBC is there's a fantastic video of a guy taking out 2 centrals and replacing them with implants, doing the whole surgical procedure without any local anaesthetic, purely using hypnotherapy. Now, this demonstrates that it can be done. What I would like to instill in you is that with really great technique in delivering local anaesthetics, with some careful language, with being aware of what we're saying and being aware of how our words can influence somebody, by using great materials and everything else, we can deliver painless, completely comfortable, amazing dentistry for our patients repeatedly, systematically, every single time. So with that in mind, I want to cover a couple of subconscious influence principles. And this is kind of giving you some information about how our subconscious works. So, for example, the first key principle for me is that the subconscious mind does not process a negative. The subconscious mind does not process a negative. It's impossible to process a don't, a won't, a mustn't, a can't, or a wouldn't. Our subconscious is just not equipped to handle that. The conscious mind is a mind of words, and the subconscious thinks in pictures, sounds, and feelings. So if I were to say to you, as you're sat watching this webinar, don't think of a blue tree. In order for you to not think of a blue tree, your subconscious mind has to think of a blue tree in order to come up with something different. Whether that's a green tree or whether it's a blue elephant or something even completely different, even for a nanosecond, you had to think of a blue tree. So in life, I used to say to my daughters before they were, older, I'd say, sweetheart, don't spill the drink. Now, for a 3-year-old or a 4-year-old, even for a 24-year-old, you have to think about what spilling a drink is in order to process and come up with a picture, sound, movie, or internal representation of what not spilling a drink is. So invariably, what I was doing without realising it is I was increasing the likelihood that the girls would spill a drink. Equally, if I'd say to somebody, careful, don't trip, they have to process in their head what tripping is in order to know what not tripping is. In fact, I had a friend, she was a catwalk model, is a catwalk model, and she would, particularly when she wore a long dress and particular high heels, she would rehearse in her head. She'd say to herself, as she got on the catwalk, don't trip, don't trip, don't trip, don't trip. And invariably, she rehearsed it that many times that she became really good at tripping. She linked the high heels, the long dress, and that fear of tripping, and it became second nature. She was brilliant at it. And so, what do we do when we're in the surgery, when we're looking after patients? Do we say things like, don't worry? Do we try and reassure our patients by saying, it's okay, don't be scared? Now, I completely get that we have a positive intent. Our intent as clinicians and team members is to ensure that our patients have the best experience as possible, and we want them to feel comfortable, and we want them to be comfortable and not be in pain. But if you understand that the subconscious mind can't process a negative, in order for them to understand what don't be scared is and don't worry, they have to process worry, they have to process scared, they have to process what nervousness is. And the key for us is that we may be reading our patients thinking that they're nervous or they're worried or they're whatever. In actual fact, we're heightening that, we're increasing that. We're increasing the likelihood of them processing that. Imagine little Johnny. You've had this, right? You've had a 4-year-old come in with mum. He sat in the chair and mum's turned around and said, it's all right, doctor. I've told little Johnny not to worry. You know that your heart went, oh, mum, you didn't, did you? You know that she had the best intentions. She wanted little Johnny. Of all the people, mum wanted little Johnny to be happy. But we all know that actually our hearts sank. You see, that's the thing about NLP. I'm only making you consciously aware of what you already kind of knew. You kind of knew this stuff because it makes sense. And you go, yes, I felt that. When Mum turned round to little Johnny and went, I've told him not to worry, you kind of go, oh, Mum. And that's what we do. So I want to encourage you to begin to catch yourself coming up with negative phrases. Use this as a team building exercise. Do a lunch and learn, for example. Sit down and come up with all of the things that you guys come out with on a daily basis as a negative phrase when you have a positive intent. You won't have many. You'll only have 5 or 6 go-to phrases that you come up with. And I want you to take those phrases and then come up with a positive version of it. Write them down and then practice them, because it will take a bit of practice, okay? So, for example, if you look at the phrases that I've come up with, and by all means, initially use the ones that I've done, but you'll come up with your own that feel more like you, or they sound better to you, or they may look better to you, and actually you'll find your own way through this. But it's okay, don't be scared. I would turn that to, I'll make sure you're relaxed all the way through. And I say this to my patients. I also say this when I'm going to give local anaesthesia. I'm going to say this before I give an injection, before I do any treatment. And I ask them and put them in control. And also I'm going to use positive phrases in order that I can create a positive internal representation for them. I'm going to make sure that you're comfortable. And it's okay, stay calm, stay relaxed. Everything's absolutely fine. So what about our marketing? What about the material that we're using in our lounges, in our waiting rooms? What about our written communication with our patients, our leaflets, our signs, all of that sort of thing? You know, this sign here, it's beautiful, what a fantastic photograph, and it has a positive intent, yet pain-free. I have to process and think about what pain is. And imagine little Johnny, who's never seen a dentist before, but a year ago he did fall off his bike and break his arm. His internal representation of pain will be very different from what yours is and what mine is. Still avoiding the dentist? Fear, discomfort, positive intent, but it's generating an internal representation of what that is. Same with this, pain-free. So why don't we change that? Why don't we look at our advertising and our written word and look at maybe creating a better internal representation? We still have the same positive intent, and yet we have a better chance of creating this relaxed sense within our patients so that we can look after them with them being much happier. The marketing materials that you're using, overcoming your fear, and all of these other things, specific fears, pain-related, unpleasant. And then we look at pain-free and pain-free. Please just take a look at all of the stuff that you're doing. So let's recap a little bit of what we've done. We've looked at customer service, why they come and why they don't come. Is it important? You know, it really is, because what we want to do is provide comfortable dentistry. And in order to provide comfortable dentistry, I want to make sure that I'm doing a really good injection, right? So my technique is paramount. I'm going to use topical. I'm going to use great equipment, great local anaesthetic. I'm going to be very careful of my bevel. I'm going to invoke the gate theory because I want sensation of touch to pass before the sensation of pain. And I'm going to be using language and distraction in order to affect the top-down modulation of that gate theory as well. I'm going to close the gate to pain when I give the anaesthetic, because I know the anaesthetic is going to look after me and the patient after I've been able to give it. Then we looked at language. Is language important? There's a gazillion language skills that I could teach you, but within this webinar, there's only really a couple that I can go through. So let's go back to the original questions I asked you right at the beginning of the hour and 10 minutes this has been, and ask you again, how did you verbally set up giving a local anaesthetic? Will you now reconsider the words that you're using or the phrase that you use? Will you reconsider the phrase that you use to reassure your patient? Hey, don't worry, it's not going to hurt, there won't be any pain. Change those into a positive. Do it as a team exercise. Catch each other out. Be playful with it, because you'll get better and better and better at this. And then finally, I want you to think about your LA technique. I'm going to show you the video now, unannotated, and then I'll show you again with annotations. Consider coming up with a systemized way of approaching giving local anesthesia that ensures that your patient is just not aware of it. So just watch this video. Great stuff. Okay, so this topical gel that I'm rubbing in just makes the gum feel completely comfortable. Good stuff. Okay. Thank you. So you're just going to feel me press just a little bit on the gum, and then you're going to feel me wiggle slightly. Good. I'm just going to sit here for about just 5 or 6 seconds. Good. Well done. Excellent. And relax. How was that?
Literally, that's the first injection I've had that I haven't felt. No, I promise.
Brilliant.
Yeah, that's great.
Thank you. Okay, so what I've done, just to let you know, we used that bubblegum topical, which numbs the gum. I've then given the injection. I've given a small amount, and what that's doing now, you'll start to feel this begin to get more numb and more numb as time goes on. And then I'm going to just go back in now, and you should feel literally nothing but me touching. Same again, because I'm going to lightly wiggle. Excellent. And that's it. So now I stay here for about 30 seconds, okay? And we'll just very, very slowly put in the local anaesthetic in. Good, well done. Excellent. And relax. You okay?
Good.
Good stuff. Thank you. So now let me replay that video, and I'll annotate it of the bits that I'm doing in case you missed anything. And then if you want this video with the annotations, I'll very gladly send that to you. Probably upload it to YouTube, but there'll be a number to text. If you just text Septodont to that number, we'll send you the link so that you can have a look at it and add value to it. Find your own way of doing it, make it better than mine. What I've found with my technique is I'm able to deliver this local anaesthetic with patients like that going, my goodness, that was fantastic. Didn't feel a thing. Great stuff. Okay, so this topical gel that I'm rubbing in just makes the gum feel completely comfortable. Good stuff. Okay. Thank you. So you're just going to feel me press just a little bit on the gum, and then you're going to feel me wiggle slightly. Good. I'm just going to sit here for about just 5 or 6 seconds. Good. Well done. Excellent. And relax. How was that?
Literally, that's the first injection I've had that I haven't felt. No, I promise.
Brilliant.
Yeah, that's great.
Thank you. Okay, so what I've done, just to let you know, we used that bubblegum topical, which numbs the gum. I've then given the injection. I've given a small amount, and what that's doing now, you'll start to feel this begin to get more numb and more numb as time goes on. And then I'm going to just go back in now, and you should feel literally nothing but me touching. Same again, because I'm going to lightly wiggle. Excellent. And that's it. So now I stay here for about 30 seconds, okay? And we'll just very, very slowly put in the local anaesthetic in. Good, well done. Excellent. And relax. You okay?
Good.
Good stuff. Thank you. So I hope you enjoyed that. Please, we'll send that to you if you're interested, you'd like to see it again. If you text Septodont to that mobile number that's there, that will then forward you the link to that video. We've uploaded it to YouTube. And if you'd like some more influence training, by all means visit dentalinfluencetraining.com or join me on one of my training courses. We've got dates throughout 2018 for influencing smiles, and we'll be releasing dates on influencing more smiles at a later date. The reference above, please go and Google Darren Brown's advertising agency task. It's about 8 minutes long, and it will demonstrate to you the effects on our subconscious mind, the fact that our subconscious takes all of the information in. And the London Bridge Operating Theatre video, it's only about 4.5 minutes, and that will show you the power of words, how we can change somebody's perception of pain. And I just want you to really see that as an educational video demonstrating to you that your words are important. And there's lots more that you could learn about the power of influence and the influence of language. So by all means, come and join me. Thank you ever so much to Septodont for this webinar, and for Dental Practice putting it on. And I'm available to answer any questions. You can contact me separately if you wish to. By all means, email me, or I'm going to be on to answer any questions for this webinar. Thank you very, very much for having me. Cheers.